but God disposes. We thought of planning this conference in July 2020, but as the COVID era is there, as you know, we could not organize it on that days. So we are making it a virtual conference. Everything has advantages and disadvantages. The advantage is now we are able to have international speakers in our conference. That is the advantage. In these 2 days, we have free papers, orations, symposium, and I hope all of you will enjoy this 2 days academic feast. The APMC has given 6 credit hours for it. So all of you should be logging on to your sessions. Otherwise, you will not be getting the credit hours. Everything is electronically recorded. So if you're not logging in, you will not get your credit hours. So ensure yourself to be logging on to the sessions always. There are few guidelines for the conference. The hall one is neurosurgery, that is Bal Parmeswar Hall. Hall 2 is V. Satyanarayana Hall, that is neurology. Hall 3 is Sir Arthur Cotton Hall, it's a common hall. Orations, common sessions, everything will be uh, transmitted from that hall. So everybody can change from one hall to another hall whenever you like, just like any other conference. I hope all of you will enjoy these 2 days academic feast. Thank you, one and all. Now the free paper session starts.
రాజు గారు సార్ గుడ్ మార్నింగ్.
విజయశేఖర్. వీడియో పెట్ట రావట్లేదు.
ఇదిగో వీడియో మ్యూట్ పెట్టాను. పెట్టాలా వీడియో?
మన ఫోటో రావట్లేదు.
వస్తది ఇదిగో.
Sir, good morning, sir.
Good morning. How are you?
Fine, sir.
Can you hear me?
Yes, sir. Yes.
You can hear me okay? You are muted.
Sorry. Sorry. sir.
Now I can hear you.
Sir,
You're muted again.
oh, it is by
Ah.
default. Sorry, sir.
Okay.
Sir,
So,
there are other presentations going on in parallelly uh, in two more platforms. So this will be a parallel session till 10 o'clock.
right.
At 10 o'clock, both of them will be closed. At 10 o'clock IST, sir, Indian Standard Time. Probably by 10:10 we will be able to, both the halls will be clubbed and it will be a common.
So, Indian Standard Time.
Observing those presentations.
So 9:30 to 10:10 Indian time, there is a lecture on aneurysm surgery, I believe.
Yes. sir. Yes.
So I was thinking that
After
I'm
that will be yours, sir.
fine. Are those talks on a different link? A different hall?
No, they also will be, they are on different links, sir. Because they are the guest lectures separate for neurosurgeons and neurophysicians.
Got it.
And yours is an orations, symposia, and they are common to all the specialists, sir. So both neurophysicians and neurosurgeons will be attending your session. So that is a common session, sir.
So for the aneurysm talk, which is, I think, 9:30 your time,
Yes.
if there is another link, I can get onto that and
Yes, sir.
listen to that.
I'll be just forwarding you, sir, the other link also. You can meanwhile join here those presentations also. I'll be just forwarding you.
Wonderful. And
Okay.
maybe 5 minutes before my talk comes on, if you could have Dinesh just get on the online with me, make sure that
Yes, sir.
the lecture and all that gets set up okay.
Yes, sir. Yes. I'll be just sharing the link for other two also. You can join meanwhile if you have some time.
Okay.
Okay, sir. Bye, sir.
Wait,
I'll be attending the.
here, it is almost 10:30 at night. So
Actually, we should have kept yours a little bit earlier also. Because you told. Anyhow, sir, just 1 minute.
no
1
problem.
hour.
No problem.
Okay, sir. Bye, sir. Dinesh.
was beneficial for the management of traumatic brain injury and is associated with better clinical outcome. CESNOS may requires, CESNOS may requires expertise in skull-based and microsurgery. Sir, good morning, sir.
Yeah, good morning.
Am I audible?
Yeah, you're audible. Go ahead.
Yes, sir. My
Between the age of
మార్చేసారు.
Can you hear anyone now?
Mhm.
Where only can see his face, huh?
Where I can't see.
Video పెట్టే that
ఈ హాల్ 3 కదా
My vision should be muted. వాళ్ళు ఫ్రీ మనకు తెలీదు అక్కడ ఏమో ఐడి ఇచ్చారు అదే పెట్టాం వచ్చిందా వీడియో muted but I can hear people. Close that and put it on the side.
విచ్ వన్
Okay, side లో పెట్టు. Oh, this is going to be a problem, right? Lights only కనిపిస్తాయి.
5 minutes టు గో అమ్మా కమాన్ ఏది నాకు ఒకసారి కుర్రడు ఫోన్ చేస్తున్నాను
Yeah, you know why? Because your voice will come through.
స్టాప్ వీడియో
ఇంకొంతమంది జాయిన్ వస్తాయి కదా
వీరేంద్ర ఓకే ఇలా సరిపోద్దా ఇంకేమైనా మార్చాలో చెప్పండి
ఓకే సరిపోతుంది సరిపోతుంది
No, sir, he light up.
దిగేస్తున్నా చైర్.
Hello.
Kannadi.
శేఖర్, గుడ్ మార్నింగ్.
Good morning, sir. And on behalf of AP Neurocon 2020, I invite Dr. Dayanandra's oration, Improving Outcomes from Severe Traumatic Brain Injury by Dr. Raj K. Narayan. I now invite chairpersons Dr. Vijay Shekhar sir and Dr. Raj Shekhar Kennedy sir.
Thank you very much, organizers. And I profusely welcome all the delegates for this common session and the prestigious oration on Dr. Dayanand Rao. I just want to make sure the other hall also have finished their proceedings. Hall 2 also. They also have joined. Raj Garu, can we proceed with the session? Now we have with us Dr. Raj K. Narayan, Professor of Neurosurgery, to deliver this oration. And I request my colleague, Senior Neurosurgeon, Dr. Raj Shekhar Kennedy, to introduce about Professor Dayanand Rao, on whose name this oration has been instituted. Dr. Raj Shekhar Kennedy, please.
Thank you, Dr. Shekhar. Good morning, everybody. Welcome to the AP Neurocon. We are about to start the Dr. Dayanand Rao oration. Dr. B. Dayanand Rao, a father figure of neurosurgery in Andhra Pradesh, did his MBBS and MS General Surgery from the Andhra Medical College and joined the erstwhile Nizam services as a civil surgeon. He worked as a district medical officer and a surgeon. Identifying his sincerity and hard-working nature, the then Director of Medical Services, Major K.N. Rao, had chosen him to go to Bristol, United Kingdom, for special training in neurosurgery. On his return, he established the Department of Neurosurgery in Osmania Medical College in 1957. His classical articles include papers on extradural hematomas, anatomical dissections of circle of Willis, cranioplasty using methyl methacrylate, and many more. He used to stress that we have a goldmine of craniocerebral injuries to contribute to knowledge. The first course offering of MCAP was started by him in 1971. He has also worked as the principal of Osmania Medical College and the additional director of medical education. Apart from being a humane medical man and an expert surgeon, Dr. Rao was an exponent of Carnatic music and written a book on the history of Carnatic music. He passed away in 1997 after a brief illness. His son studied medicine and later on became a neurosurgeon. It was unfortunate his son preceded him in death. Dr. Rao was a past president of the Neurological Society of India in 1968 and an honorary member of the APNSA. Over to Dr. Shekhar.
Professor Shekhar, could you unmute yourself, please?
Yes, I'm sorry for that. So Dr. Raj Narayan, I'm sorry for that. Dr. Raj Narayan is a professor and chairman, Department of Neurosurgery, and director, Northwell Institute of Neurology Neurosurgery at New York. He has an illustrious career, and it is fortunate that he is from India. He is born in Secunderabad, India, and he underwent his medical schooling from the prestigious Christian Medical College, Vellore, in 1975. Subsequently, he did his residency in neurosurgery from Medical College, Virginia. Later, he obtained fellowship from the National Institute of Health, Bethesda. Later, he has worked at various capacities in Houston, Philadelphia, Cincinnati, and he has been working as a professor of neurosurgery from 1995 onwards. And friends, he is chairing and heading the Department of Neurosurgery, the Zucker School of Medicine, and Northwell, and director Northwell Institute of Neurology and Neurosurgery at New York. He has many selected accomplishments. In fact, it is quite a big list, and he is a diplomat of American Board of Neurological Surgery, and he is an honorary member of Alpha Omega Alpha Epsilon chapter and elected in 2001. His main areas of research interest are head injury and the brain tumors. He has published more than 120 publications which are peer reviewed, and he has authored more than 60 chapters in various textbooks. The neurotrauma major textbook, he was the co-editor, and he's a true academician. He helped develop the traumatic brain injury management guidelines, which are followed by many countries across the globe. He served as a consultant to the CDC, the FDA, and NIH, and several other companies. He is the chairman, Joint Section on Neurotrauma INS, and the Congress of Neurological Surgeons from 92 to 94. He was a guest examiner for the American Board of Neurological Surgery till 2009. And he is the recipient of prestigious William Fields Cavaness Award in 1997. He is a member of American College of Surgeons Committee in Trauma, and he is the chairman American Brain Injury Consortium 99 till date. Friends, he is bestowed upon the Best Doctor Award of several states and also America, the Philadelphia, Cincinnati, and many other states. He is the chairman, Joint Section on Neurotrauma and Critical Care of ANS and CNS. And friends, he has helped over 75 neurosurgeons from 1985 till date. So that is a very illustrious career. And he has trained so many neurosurgeons throughout his career. Friends, he is continuing his research in the field of neurosurgery with an interest in the traumatic brain injury and brain tumors. And to his bag, he has credit of professorship, 75 visiting professorships and honored lectures in several countries. Friends, research is his basic instinct. He has been the principal investigator in several research projects from 1986 till date. To start with, in 1986, he has started with the identification and isolation of malignant glioma associated proteins in 1986, and the latest one is trigeminal nerve stimulation to modulate the cortical spreading depolarization after the TBA as a co-investigator, which project is still going on. He has several peer-reviewed publications. Friends, I know you are all very eager to listen to him, but not to my lecture. So these are only few works of Professor Raj Narayan to present the prestigious Dr. Dayananda Rao oration. This is Dr. Dayananda Rao, who has worked as a almost first neurosurgeon who has available round the clock 24 hours for the traumatic brain injury patients way back in 90s. So I request Dr. Raj Narayan, who is the most befitting candidate to present this great oration, who has interest in the traumatic brain injury. I now present Dr. Raj Narayan. Thank you, sir.
Can you all see my screen?
Your screen is not seen, sir.
Sir, kindly share your screen, sir.
I'm trying to do that. Let me see.
Down there's an option, green color option is there, share screen. Click on that and share, sir.
How about now?
Yes. Yes, sir. We're able to see, sir. Thank you.
Okay.
You can switch on to slideshow mode, sir. Yeah.
Okay, can we? Okay. Am I good now? Can you see? Is it showing up okay?
Yes, very well.
Okay.
Thank you.
Okay, great. Dr. Vijay Shekhar, thank you so much for that very, very kind introduction. I'm very honored to be able to deliver the Dr. Dayanand Rao oration to this association. I am greatly honored to be part of this meeting, and it is a wonderful thing for me to be back with my roots, so to speak. As Dr. Vijay Shekhar said, I was born in Secunderabad and did my high schooling from there. So this whole area is very near and dear to my heart. I'd also, before I get started, like to thank Dr. Sheshagiri Rao, the president of the association, of course, Dr. Vijay Shekhar, Dr. Ravi, Dr. Venkat Raju, Dr. Raj Shekhar, and of course, Dr. Varaprasad, and my good friend, I have done a lot of work with over the years. I'm going to give you a very quick overview of work that I've been involved in, and this is not just my work, but work that I've done along with several of my colleagues over the years in the pursuit of improving outcomes from severe traumatic brain injury. I was listening to some of the talks by the residents earlier on this morning, and clearly traumatic brain injury is a major problem around the world. And quite honestly, I don't think it gets the attention that it probably deserves, given its frequency. So let's get started. I just want to give you my life in a nutshell. Let me just minimize this. So I went to the Hyderabad Public School in Begumpet, finished in '67. Then I went to medical school at CMC Vellore. After finishing from there and doing a year of neurosurgery with Dr. Jacob Abraham, I went to the US and was fortunate to have got a residency at the Medical College of Virginia in Richmond. After finishing my residency, I went to the National Institutes of Health for 3 years to prepare myself better for research in neurosurgery. Then took my first job at Baylor in Houston and was on the faculty there for 10 years, following which I got the chairmanship at Temple University. And I was there for 7 years, and then at Cincinnati for 7, and now at the Zucker School of Medicine at Northwell Health in New York for the past 12 years or so. So a little bit about where I work. This is a picture of New York. Manhattan is here. Can you see my arrow?
Yes, sir. Able to see.
Okay, good. So this is Manhattan, and this is Long Island. You can see the size of it. Long Island is bigger than some states, and it is a very long island. It's about 140 miles east-west and about 40 miles north-south. So our health system, all the H signs that you see are all hospitals that are owned by Northwell Health. And all the red dots are physicians' offices, yellow dots are imaging centers. So just to give you an idea of the size of this, it makes Northwell Health one of the larger healthcare systems in the country. And our neurosurgery department is based out of these hospitals, which are listed on the left. And there are several other hospitals where the patients are sent on to us at one of the major tertiary hospitals. This is the mothership, North Shore University Hospital, where we have a 16-bed neurosurgical ICU with full-time neurointensivist presence. It's a level 1 trauma center and a comprehensive stroke center. Long Island Jewish Medical Center is just about a 10-minute drive from North Shore, and it is where we do a smaller amount of neurosurgery. Right next to that is Cohen Children's, which is our pediatric hospital, and that's where all the children are done. In Manhattan, we have Lenox Hill Hospital, and some of you may have seen the Lenox Hill show on television with one of my colleagues, Dr. Langer, who was sort of the star of the show. Our faculty has grown in size from 8 neurosurgeons to now 41. And some of the teaching faculty are shown here. And I won't belabor that, but we also have within the Department of Neurosurgery, 10 neurointensivists or neurocritical care doctors. And I would strongly urge, whenever possible, if you are creating a department, try to get both the endovascular surgeons as well as the intensivists all within the Department of Neurosurgery, because then people can work together much more collaboratively. We have a residency training program. We take 2 residents per year, and they train for 7 years before they're ready to go out and get board certified. This is just a rogues gallery of our residents. It's quite a diverse group from various medical schools, and they're just absolutely excellent. The Feinstein Institute is our medical research building. It's on the same campus as North Shore Hospital. And we also have a very close working relationship with the famous Cold Spring Harbor labs, which are about half an hour away, which allows our residents to do research should they choose to do it at Cold Spring Harbor. All right, so let's talk about head injury. So I started training in Richmond, Virginia, which is about a 2-hour drive south of Washington, DC. At the time that I got there, which was in the mid-1970s, head injury was treated very poorly. Most people were not really interested in it very much. And the way it was managed for the most part is leaving the patient in the corner, and if the patient survived, then fine, and if not, then that's fine. And there were surgeons who would spend 12, 14 hours working on a patient with a brain tumor, but have zero interest in head injury. So we were clearly dealing with a very, very huge problem. This is like David and Goliath. We did not have a whole lot to go on, and we were obviously dealing with a very, very big problem. The brain inside the skull was sort of a mystery box. We didn't really understand what was going on inside the cranium, and let alone what to do about it. So over the past 43 years that I've been involved with this, I've tried to break down the different things that we've done into 6 different approaches. The first was aggressive treatment. I'll come to that in a second. Understanding cerebral pathophysiology, then developing some technology so that we can better monitor patients, then trying different drugs in pharmacological trials, developing management guidelines, which have been extremely useful, and finally, developing non-pharmacological treatments that might help. So let's talk about the first phase, the aggressive treatment with, as I mentioned, at the time, people were not treating these patients very aggressively. So we were fortunate at that time to get an NIH grant to start to look at whether the outcome from traumatic brain injury could be improved with aggressive treatment, which meant early intubation, immediate CAT scanning, immediate surgery if it was needed, neurocritical care in the post-operative period, and so on. Understand that CT scans had just become available a couple of years before that. So it was a big change. So one basic question was, can the outcome from traumatic brain injury be improved with our efforts, or is it established right from the start and it doesn't matter what you do? And I hope in the next half an hour or so to be able to convince you that all our efforts do make a difference. So head injury is a process and not just the event. And all of you know that apart from the initial injury, there is all the secondary damage that occurs, both systemic and CNS related. Now, the working hypothesis, therefore, is that providing injured neurons with an optimal milieu for recovery will allow them to survive and lead to improved outcomes. That has been our basic hypothesis. So how do you do that? How do you give the brain cells the right conditions to recover? So as I mentioned a minute ago, early intubation, rapid transport to a designated trauma center, prompt resuscitation, early scanning, prompt surgery, and prompt attention to detail. So this is one of the first few papers that I published, and it has actually stood the test of time. We looked at our experience with those early patients with head injury and looked to see, because all of them were getting ICP monitoring if they were comatose, we found that patients who had an abnormal CAT scan, whether it was a subdural, epidural, contusions, if there was an abnormality, they had a high incidence of raised intracranial pressure. However, even if their scan was normal, in comatose patients, if they were over 40 years old, if they came in with hypotension, or if they had motor posturing, if they had 2 out of these 3 features, even with a normal CAT scan, they had an elevated ICP. So the guidelines for ICP monitoring was to monitor all severe head injury patients with an abnormal CAT scan, and even with a normal CAT scan if they had 2 or more of the features mentioned.
Right. That's it.
Now, ICP treatment threshold, I won't, in the interest of time, won't belabor this, but somewhere around 20 to 25 is the upper limit of what is generally acceptable. And the technology, I'd say that a simple ventricular catheter is the lowest cost and most reliable way of monitoring ICP, and it also allows for therapeutic drainage. The fiber optic and strain gauge devices are much more expensive, and if you have them, you can use them, but they're not as good as a simple catheter. We published a whole bunch of papers, which I just list there for anybody who's interested. So then, having shown that we could treat these patients aggressively and get better outcomes, we started to try to understand the cerebral pathophysiology. And I've mentioned the names here of all the several people with whom I worked in making all of this happen. This was in a 10-year period between 1985 and 1995. This paper by Randy Chestnut is an important one, because it shows that in patients with severe traumatic brain injury, if they have neither hypoxia nor hypotension, their mortality rate is 27%. With hypoxia, it goes up a little. With hypotension, it doubles. Please, somebody is not muted. If you could mute, thank you. So hypotension is bad and has to be avoided. Sir, can you please mute? Please mute. This, again, these are studies done by my colleague in Houston, Claudia Robertson, showing that patients with elevated cerebral blood flow had the best chance of a good outcome. And those with reduced cerebral blood flows had the worst outcomes. In the interest of time, I'll skip through that one, but suffice it to say that cerebral perfusion pressure should be maintained at a minimum of 60 millimeters of mercury, and you should not push it a whole lot above 70 because of pulmonary complications. This was a study done by one of our fellows, Zev Feldman, who subsequently became the president of the Israeli Neurosurgical Society. And what he showed was that keeping patients nursing at 30 degrees of head elevation was a good thing. And the concern that we had that by putting the patient up, that their the cerebral perfusion may go down was not true. So it is okay to nurse the patients with the head of the bed elevated 30 degrees. And there are a whole bunch of papers on cerebral metabolism that Dr. Robertson and I and several of our fellows published over those years. And based on all of that, somewhat formulaic or menu-driven way of looking after head injury, I've listed here: keep the systolic blood pressure over 90, ICP monitor all patients who are GCS of 8 or less, keep the perfusion pressure between 60 and 70, do not let them become feverish, keep the serum sodiums over 140 and use hypertonic saline if you need to. Brain oxygen monitoring, we'll talk about in a minute, but keep that over 15. Keep the blood sugar between 80 and 140. Prevent seizures and repeat CAT scans early and often to see what is going on. Decompressive craniectomies if ICP is not otherwise controllable. There is a study going on currently, and we are part of this study. It's called Boost 3, and it is just getting started for comatose patients. And we are going to try to answer the question, is it better to manage the patient based on intracranial pressure data, or is it better to manage them using brain oxygen levels? The answer to that is not known yet and will not be known for probably another 2 to 3 years. Now, the phase 3 of our efforts were in developing technology, and I've listed people that I've worked with on that. Dr. Chunyan Lee has worked with me now for about 15 years. She's an electrical engineer and worked with me both at Cincinnati and now in New York. Going back to ICP monitoring, this was described as far back as 1951 by Gulami and Jani, and then popularized by Lundberg in his 1960 paper. As I mentioned, a simple catheter connected to a simple transducer is really probably the most effective way of doing this. The brain oxygen monitoring is done with the Lycox monitor. generally you need to keep the brain oxygen levels above 20. The microdialysis is not used very much except for research purposes. So we worked on several different technologies, but I'll just mention that because it was not possible to measure a lot of things with one device, we started to work on the Canary Multisense Monitor, which is a MEMS technology-based monitor, where on one catheter, you can monitor a variety, several things, including temperature, blood flow, ICP, glucose, lactate, pyruvate, and so on. And we have used this and tested it now in lab animals. And here you can see an example of what this might look like. This is a middle cerebral artery occlusion model, where when you occlude the middle cerebral artery, you can see the EEG dropping, the DC potential, which we'll talk about in a second, spreading depolarization occurs soon after. The oxygen level drops, the glucose level drops, lactate level goes up, temperature spikes, cerebral blood flow drops, and eventually the intracranial pressure rises. I wish I could tell you that we have this for use in human beings, but to take it from the lab to human testing requires several $1 million of investment. And we are at that stage now of having to raise that money in order to be able to test it and to prepare it for human use. A lot of publications that we had based on this. As I mentioned, Chunyan Lee and Jed Hartings and Laurie Shutter were involved with this. This led us to looking at a phenomenon called cortical spreading depolarization in the injured brain. This is something that had been described several years ago, but actually my colleague Jed Hartings took the lead on it and started to study it in humans. And what we are finding is that this is a wave of depolarization that spreads across the brain and is probably responsible for the fluctuation in the exam that you see in patients from minute to minute and hour to hour. And we have found that by putting a strip electrode on the surface of the injured brain after evacuation of a hematoma, you can continuously record electrocorticography in the ICU. And if you do so, you will see that there are these waves of spreading depression or depolarization that occur and they spread from one part of the brain to the other. And Dr. Hartings has continued this work, and they have found that the incidence of cortical spreading depolarization is very high in all of these different conditions. So various pharmacological interventions have been attempted, including ketamine, to try to suppress cortical spreading depolarization. But we have been actually looking at it in a different way. This is an animal model, a mouse model of trigeminal nerve stimulation. The trigeminal nerve, as many of you know, also is connected to the cerebral arterial vasculature. So stimulating the trigeminal nerve can cause cerebral vasodilatation. And this may be a strategy for improving blood flow to the brain. And I don't have time to get into details on this. This has been published in a paper in Scientific Reports. But basically what you find is that trigeminal nerve stimulation can result in an increase in cerebral blood flow. And it reduces the size of an infarction. And in this rat model, it shows that it reduces mortality, and it may be, therefore, both for large strokes as well as for traumatic brain injury, a new approach to how to go about this. Now, phase 4, I've been involved in a whole bunch of pharmacological trials, meaning drug trials for TBI. And as you know, there's a lot going on in the injured brain, and we are only seeing a little part of it. I'm going to skip over this, but just to list for you a whole bunch of trials that have been conducted, and most of them have not shown really any promising effect, except for NOVO7, which reduces the growth of hematomas. Progesterone looked really good in phase 2 trials done in the US and in China. So we